Hi, this topic is acquired hemolytic anemia. What is hemolytic anemia? Hemolytic anemia is a form of anemia due to increased rate of red cells. It is divided into inherited acquired type. Coming to the classification of acquired hemolytic, warm autoimmune hemolytic anemia, autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia, 80% of cases. What could be the cause? It can be a primary or idiopathic. Secondary causes would be lymphoproliferative disorders and an autoimmune disorder. Into cold autoimmune hemolytic anemia, percentages of 16 to 32%. The most common cause will be predominant disease. Paroxysmal cold hemoglobinuria. The most common cause for cold agglutinin for the secondary certain hypoplasma pneumonia, infectious mononucleosis, and the lymph. Coming to paroxysmal cold hemoglobinuria, the cause will be idiopathic or secondary infections like syphilis. Another classification is drug-induced autoimmune hemolytic anemia, transplant-associated autoimmune hemolytic hematopoietic stem cell transplant, based on minor immune solid organ and passive antibody transfer. So coming to immune hemolytic anemia, by the definition, immune hemolytic anemia is a clinical condition in which the IgM bind to the red cell surface antigens and initiates a red cell destructions via the complement system. Immune hemolytic anemia is classic autoimmune, autoimmune, drug-induced. It is mainly based on antigenic stimulus responsible for the response. What is autoimmune hemolytic anemia? Autoimmune hemolytic anemia is the exposure to allogenic red cells as occurs in the conditions like pregnancy, blood product transfusion, and transplantations, resulting autoantibody shows activity toward autologous red cells. Now coming to autoimmune hemolytic anemia, it is characterized by production of autoantibodies directed against the red blood cells. Usually, autoantibodies are directed against high incidence and the type is drug-induced immunolytic anemia. Here, the drug-induced antibodies are directed against either the red cell bound drugs or red cell antigens. In autoimmune hemolytic anemia, the autoantibodies attach to and lead to destruction of endogenous red cells, resulting in anemia. As previously discussed, it is classified based on by temperature reactivity of antibodies. Warm antibodies warm antibodies get strongly at 37 degrees Celsius. Cold antibodies get strong 0 to degrees Celsius. Main predisposing condition causes one is idiopathic or primary and secondary will be certain lymphoproliferative disorder, anything infections, as I already told, it could be a mumps, measles, viral infections, infectious diseases, mycoplasma pneumonia, anything. Reacts strongly at 37 degrees Celsius, whereas cold reacts strongly between the temperature of 0 to 4 degrees Celsius. So, what are the features of warm antibodies? So, warm active antibodies have higher affinity to disease at 37 degrees Celsius. The common antibody binds is IgG type. So, it may be or may not fix the complement. It enhances the main mechanism for warm antibodies. It enhances clearance to react to Fc receptor mediated phagocytosis. It has a specific clinical role of Once it binds to the Fc receptor mediated phagocytosis, and it gets trapped into the splenic and there will be phagocytosis of RBC occurs, leads to extravascular hemolysis. Clinical features of warm active and active autoimmune hemolytic anemia with the insidious onset symptoms of anemia will predominate. Have the symptoms of fatigue, weakness, then pallor, for the autoimmune hemolytic anemia, right? It has episodes of acute crisis in intercyanosis and Raynaud's phenomenon. Autoimmune hemolytic patients, anemic patients have serious underlying disorders such as hereditary disorder or autoimmune disease. The clinicians has to investigate these patients in detail. This is that peripheral sphere picture showing warm antibody types that will be equalizing fungus in this case. It is phagocytes, like cells. The classic example for immune type warm antibody. Peripheral picture shows microspherocytes and its. Now coming to pathogens, warm active antibody. The individual not the individual immune system not able to recognize these self-antigens. Here the antibodies reacting against self-antigens and the subsequent tissue because the main triggering factors will be genetic factors, infections, inflammatory disorders, drugs, and lymphoproliferative disorders. This is the main mechanism of active antibody type. Here, warm antibody actual antibodies, I told already, is IgG type. So here the IgG binds to Fc receptors on splenic macrophages. Once it is bind to the splenic macrophages, it produces proteins. The macrophages produce, it enters the RBCs and there will be complete lysis of RBC occurs. This is the then direct and complete phagocytosis because this is the one type of mechanism happens in autoimmune hemolytic anemia. One more is partial phagocytosis. Here the attached portion of the RBCs alone get trapped and detached. So there will be reduced in size of RBCs, the spirocytes are formed, and finally it gets trapped inside the spleen and there is complete hemolysis occurring. So what is the so now summarize the autoimmune hemolytic anemia, warm active antibodies. As I already told, it's react strongly at 37 degrees Celsius. It has high affinity to RBCs at warm temperature, 37 degrees Celsius. It is mainly IgG or may not, thus they complement. It enhances clearance to Fc receptor mediated phagocytosis and extravascular hemolysis occurs. So the most common clinical features will be symptoms of anemia. It is an insidious and onset. This is the peripheral pictures of showing many spirocytes and microspirocytes. Some fragments are seen. This is the mechanism. Here, the IgG binds to receptors on splenic macrophages. Once it gets binds to the splenic macrophages, the macrophages produce pseudopores. It engulfs the RBCs and complete direct hemolysis phagocytosis. So, in partial phagocytosis, the RBC membrane attached to that alone will get trapped and this finally so that will be reduced in size and it gets trapped in the spleen to complete hemolysis occur. In cold active antibodies, it has higher affinity for RBC increases as the temperature decreases to 0 degrees Celsius. It is mainly IgM type. It has fixed complement. It is a complement mediated breakdown. Here, either it can be vascular lysis or hepatic mediated clearance. This is the mechanism for cold active antibodies. It has a higher titer of IgM type, so there will be efficient complement activations and direct intramuscular hemolysis by cytolytic membrane attack complex. Once it gains bind IgM type, so it activates the complement and C5 to C9 membrane attack complex. So once it gets activated, that creates multiple pores. The RBC gets lysed. This is the one mechanism. Another mechanism is the complement mediator. So the C3b deposited on RBC surface, the C3b binds to receptors on Kupffer cell and there will be immune destruction occurs. The laboratory diagnosis two criteria. First is the laboratory evidence of hemolysis, another serologic evidence of autoantibodies. Coming to what are the signs of hemolysis? There is a increased reticulocytosis, increased in retic count, then unconjugated bilirubin. Serum LDH level will also get increased. Serum hemoglobin level also get another hemoglobinemia, hemoglobinuria, hemosideruria will be decreased. The demonstrations. Another is RBC surface bound immunoglobulins and there will be a evidence of conflict. So the critical number required to agglutinate the RBCs IgG molecule will be 7,000 to 20,000 per RBC. For IgM molecule is 55 to 50,000 RBCs. Direct antiglobulin test. It is first described by Holmes in 1940. It determines whether the red cell have been coated in vivo with IgG or complement. This is a mechanism. First, there will be a suspension of RBCs, then antibodies to immunoglobulins complement molecules where we have to add, and it provides a necessary cross-link to elicit agglutination. So here you can see the erythrocytes. Erythrocytes in vivo antibodies coating erythrocytes. Then anti-IgG, anti-immunoglobulin reagents added after the erythrocytes are washed. Once it once we add it, it produces a IgG coated erythrocytes to become agglutinates. This test is positive for direct Holmes test. Indirect antiglobulin test, the antibodies detected in the serum or plasma. The antibodies eluted from the RBCs. So patients serum with antibodies, reagent or RBCs, antibodies to human immunoglobulins or complement molecules. The antibodies in serum and the reagent erythrocytes. We have to add the ones, then anti-IgG, anti-immunoglobulin reagent added after the erythrocytes are washed. Then reagent causes IgG coated erythrocytes to agglutinate. This test is positive for indirect antiglobulin test. Now coming to cold autoimmune hemolytic anemia. It reacts with red cell at temperature below 30 degrees Celsius. Less frequent than warm autoimmune hemolytic anemia. Two forms are there. Cold agglutinin disease. Here the autoantibodies acts as the red cell agglutinates. Another is paroxysmal cold hemoglobinuria. Here the autoantibodies acts the red cell lyses. Coming to cold agglutinin disease. 90% of cold antibodies are against I antigens and 10 capital I antigen and 10% against small I antigens. Here the main antibody involved IgM. As I already told you, autoantibodies reacts most strongly at 0 to 4 degrees. So IgM binds to RBC and agglutinates at temperature below 30 degrees Celsius. This is occurs mostly in the peripheral cooler parts of the bodies like ears, fingers, toes. It fixes complements when the blood reaches the warmer area. IgM autoantibodies associate from the red cell. The C3b remains and acts as opposite and cells are get removed by Kupffer cells in liver. So the laboratory findings will be anemia, peripheral smear shows red cell agglutinations. Agglutinations avoided if the sample is incubated 37 degrees Celsius and the slides are pre-warmed. Direct antiglobulin testing is usually positive with anti-C3 and negative with anti-IgG type. So IgG is a example for warm and active antibodies. Here in cold active antibodies, IgM type. Here in peripheral sphere, you can see the number of agglutination, clumping of RBCs in. So in pre-warmed sample, the RBCs agglutinase are disappear. So on CBC, the first suspicion is failed to obtain a valid RBC count and indices in a CBC. RBC count is artifactually low and MCP is artifactually high. It produces a spuriously high MCH value. Corrected CBC is obtained in a pre-warmed samples. Here you can see the differences between the cold agglutination sample and pre-warmed sample. Hemoglobin is 6.5. Hemoglobin here there will be spuriously increased in MCV, MCH and MCH. Now, once it gets pre-warmed, so the values are the normal or in normal levels. Coming to paroxysmal whole hemoglobinuria. Here the paroxysmal whole hemoglobinuria antibodies are polyclonal IgG type. The antibodies in PCH is directed against the P antigen found on the RBCs of individuals. The P antigen is similar to the phosphoglycogen present in many microorganisms. Infectious agents may elicit DL2 and antibodies as a result of cross-reactivity. Paroxysmal whole hemoglobinuria is acute viral syndrome in children. Hemoglobinuria occurs on exposure to immersion substance in water or taking or drink. There is acute intermittent massive hemolysis occurs due to disease. So the first early morning voided urine is dark, then subsequent urines will be clear because of the pH. Why there is a early morning voided sample is dark in colors and subsequent voided because the hemolysis occurs in concentration of hemolysis occurs in the later midnight because of acidic pH. The donor Lanssteiner is the donor Lanssteiner antibodies that is a biphasic hemolysin. Patient serum is incubated with RBCs at 0 to 50 degrees Celsius and then Celsius to produce lysis. The antibody binds to RBC at cool temperature. Complement mediated lysis occurs at 30 degrees. Lysis visible to the naked eye is a positive test. Coming to paroxysmal nocturnal hemoglobinuria. PNH is a rare chronic intravascular hemolysis caused by an abnormal hematopoietic stem cell mutation that results in circulating blood cells like GPA anchored proteins such as CD55 and CD59 on the surface of RBCs renders them susceptible to spontaneous lysis by complement. The definition for paroxysmal nocturnal hemoglobinuria. It is a rare non-vascular hemolysis caused by an abnormal hematopoietic stem cell mutation that results in circulating blood cells like anchored proteins such as CD55 and CD59 on the surface of RBCs renders them susceptible to spontaneous lysis by complement. The defect will also be found in platelets, granulocytes. The most common for this paroxysmal nocturnal hemoglobinuria is Bihajal. Bihajal means hospital in phytocycle lichen complementation classy. The most common mutation is friendship mutations. PD55, they already do. Here the results in circulating blood cells because of GP anchored proteins they lead paroxysmal nocturnal hemoglobinuria such as CD55 and CD59. CD55 means the main function of CD55 will be formation and stability of C3 and C5 proteins. This is also called PK accelerating factor. CD59, the membrane inhibitors of reactive lysis. It blocks the formation of membrane attack complex and also blocks the aggregation of light. The deficiency complement mediated intravascular hemolysis. Clinical trial for paroxysmal nocturnal hemoglobinuria is hemolytic. bone marrow failure follows. The laboratory diagnosis is anemia. Because of bone marrow failure, there will be a pancytopenia, leishmaniasis. Leishmaniasis means variation in size and the shape of the RBCs. Reticulocytosis increase in found indirect bilirubin increase again. Anemia, during hemophilia, specific risk for paroxysmal nocturnal hemoglobin test as acidified serum test. Patients' red cell get lysed and acidic presence of complement. Now coming to hemolytic disease of newborn. It is a syndrome associated with the hemolysis of fetus in utero and after delivery with subsequent bilirubin, hyperbilirubinemia. Commonly, it is commonly caused by destructions of red cell of fetus as a result of maternal IgG antibody, which causes the most common causes maternal IgG antibodies of previous pregnancy with antigen positive fetus or exposure to red blood cell transfusion directed against an antigen was better, which is present on the fetal red blood cells. The IgG antibody crosses the placenta to both the fetal antigen cause decreased red blood cells level, which can result in anemia. ABO incompatibility can also hemolytic disease cause pregnancy, but it is mild. Anti-D, the other blood group antigen causes hemolytic disease components subsequent pregnancies. This is the pathophysiology of hemolytic disease of newborn. RH negative mother, a previously sensitized to RH antigen transfusion or RH positive fetus. Stimulates the antibody production of the RH antigen. The RH antigen, either it can be an IgM or IgG. So the IgG which crosses the placenta, the antibody gets combined with the RH positive erythrocytes. So here you can see the attachment IgG antibody which crosses the placenta and gets bind to the erythrocytes. There will be removal and destruction of erythrocyte antibody complex and leads to what happens? Anemia. Anemia because of extramedullary hepatocytosis, that is also a cardiac degradation. The hydrox. Hydrox will be seen hemoglobin degradation. It will be like this because jaundice and the pictures of right. There will be common causes and erythroblastoma. The mark hepatosplenomegaly. Total anarthritis, venous tension, hypertension, hepatocellular damage, hypoproteinemia, congestive cardiac failure, hydroxyfetalis. Hydroxyfetalis means generalized passive ascites, and pericardial effusion. The test for fetal maternal age, red test, iron Bentley test, and flow cytometry, antigen cells, HbF contains something, maternal enzyme link, anti-globulin test, versions. They summarize we can see. So what is the classifications of hemolytic anemia? So how will you classify the acquired hemolytic anemia? So it is a warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, drug-induced autoimmune hemolytic anemia, and transplant-associated autoimmune hemolytic anemia. Most common cause for what warm autoimmune hemolytic anemia is primary or idiopathic. Secondary cause will be lymphoproliferative disorders and autoimmune disorders. For cold autoimmune hemolytic anemia are two subtypes: cold agglutinin and disease. Paroxysmal cold hemophilia. For cold agglutinin, primary cause will be idiopathic. Secondary will be infections like mycoplasma pneumonia, infectious mononucleosis, and lymphoproliferative disorders. Paroxysmal cold Common causes primary and idiopathic. Secondary will be infection like syphilis, mumps, and this is the definition of hemolytic anemia. Hemolytic anemia is a clinical condition in which our IgM antibody binds to red cell surface antigens and initiates the red cell destruction via the complement system under the reticuloendothelium. Immune hemolytic anemia is again classified as autoimmune, and drug induced. Autoimmune hemolytic anemia, the auto antibodies attached to an infection of red cells resulting in anemia. Autoimmune hemolytic anemia characteristic is mainly based on the temperature reactivity of antibodies. The warm antibodies react strongly at 37 degrees Celsius. The cold antibodies react strongly at 0 to 4 degrees Celsius. So, what is the features of warm active antibodies? Warm active antibodies are higher affinity at 37 degrees Celsius. Here the antibodies is type. It may or may not fix as they complement enhances the clearance to Fc receptor mediated phagocyte. Here there is an extravascular hemolysis occurs. Active antibody, the higher affinity for this, the temperature decreases towards 0 degrees Celsius time. Here it fixes the complement. It complement mediated breakdowns. The intravascular lysis occurs with hepatic mediated clearance. Paroxysmal cold hemoglobinuria, common antibodies are polyclonal IgG type. Here the antibodies in base direct against the antigen species of in paroxysmal cold hemoglobinuria, parents interventions, hemoglobinuria and exposure to cold and emissions of funds, water taking places in acute intermittent nausea, that is by variation of colors. The pronoun transgenial test is possible. Accessible functional hemoglobinuria, PNS is a rare vascular crisis caused by an acute chronic hepatic stem cell mutations that results in synthetic blood cells that react the proteins such as E55, CD59 on the surface of RBCs, resulting susceptible to spontaneous life. The result is not only seen in the RBC, in platelets, granulocytes, cytes, and lymphocytes. The most common treatment and important is paroxysmal nocturnal mutated genus P. Expansion for beta genus, phosphatidylcholine glycine, mutation class. Common mutation is shift mutation. E55 also called as the accelerating factors. ED59 inhibitors of electrolysis. Now, the main function is the mechanism here. The blocks the formation of iron and also blocks the aggregation of C9 artificially. It mediates the complement mediator intralysis. And the last topic is about hemolytic disease of RH negative mother sensitized to RH antigen transcription RH positive. It's a production of antibodies against RH antigen. The IgG type represent the antibody attached to RH positive. Right? Leads to of erythrocytes destructions occurs. Finally leads to anemia, cardiac compensations, hydroxystalis, then hemoglobin degradation leads to bilirubin, jaundice and headache. Thank you. Any doubt?